do a WebEx today talking about our efforts to redesign our residential system, and the title slide speaks to a collaborative effort. So in the spirit of that effort, my partner, or he's usually right behind me just in case the plank gets sawed off. He's so Norvig DeBuy-Saxinger is here with us as well as president of TCA. So I thought that maybe before we go through the slides, which is really an attempt to answer the multitude of questions we're getting, that Norvig could sort of speak about the effort that he and I have been leading for multiple years now about trying to do something with residential services in New York State. So Norvig?
This effort really began when it was clear that the Affordable Care Act was getting a lot of traction with the health care reform, and particularly we noticed the expansion of Medicaid coverage, and we ask ourselves, how does that play out with respect to services for substance abusers or substance disordered individuals? And what stood out was that in that continuum of care, residential treatment programs for adults were just not in there. They were not in that continuum, and not only would that affect future revenues for that service on the public side, but the private insurance also kicked in. So we said, what can we do about that? And that was like 4 years ago, 3.5 years ago, and very quickly, a number of us had some discussions and said, look, we should be able to redesign the service system and talk about it differently so that Medicaid-eligible individuals and insured individuals could get their medical and clinical services paid for in a residential venue as they get it paid for in other venues. And we were not asking anyone to pick up a room and board, full day of care. We were asking people to pick up the treatment portions. And in doing that, we took a look at, well, what residential really meant, and we quickly came to the conclusion that you could talk about 3 elements of services that are provided within the long-term, within the residential term, and we took a very close look at what services might be Medicaid eligible. We billed the Medicaid. One of the fundamental ideas was that we want to keep all of the existing revenue streams intact, available. That Medicaid, if it came to pass to be available for the service, would increase the resources available for additional staffing. We had the support in doing that of the governor's office. Saw, I think, the wisdom of that and supported us. DOB was in favor. The health department became part of the collaboration. OASAS, the commissioner, was fully behind it, and there were a number of providers that provide residential treatment, among other treatments, services as well, who served on a committee. And I think we're at the point now, several years later, where it looks like we're beginning the implementation phase. And so, Robert, maybe you'd take it from there.
Sure. So let me, before I dive into the Medicaid redesign aspects of the residential redesign, I want to touch on something Norvig referenced, which is the non-Medicaid insurance world. And just to make clear for folks that, while we've been engaged in this effort as it relates to, bringing all of our Medicaid all of our services into Medicaid managed care, we've had a parallel effort going on to bring life to the federal parity law, to get other insurance law changes which are occurring. And one of the ways, though, that we brought life to the parity law is our partnership with the Department of Financial Services, which is the New York State, that's the name for the New York State Insurance Department. And, one of the things that they did in the last couple years is they issue what's called circular letters, which are for insurance companies the equivalent for OASAS providers of a local services bulletin, and they had issued guidance last year, or a circular letter, and they also then issued model contract language, which is important, and I'll mention it in a minute why it is, but that said, and this is based on the final federal rules that came out for the federal parity law, because it referenced a residential component to the substance use disorder benefit as being part of what they label the inpatient part of the benefit for private insurance. So we asked the insurance department, well, we told them what we thought it meant, and then they opined that it did indeed require now private insurance to cover OASAS residential treatment services. So they now are part of the package of benefits that need to be offered by large group plans and insurers who are covered by the federal parity law. And the reason I say the model contract language and why it's important, in New York State, you cannot issue an insurance policy for customers to buy without prior approval from the Department of Financial Services. So when they issue language that they identify as model contract language, it's usually going to end up in your contract, or they're very unlikely to approve it. So I just wanted everybody to understand that aspect, because clearly, while we got into the mechanics of redesigning residential primarily at the start because of the Medicaid redesign efforts and our need to move all of our benefits into Medicaid managed care, there's also this other aspect, and it's another consideration for all the residential providers, is that there should be new market opportunities from private commercial insurance. And then I'll say one more thing that's sort of off the PowerPoint but is important. In the Locator 3.0 tool, which we are requiring Medicaid insurance plans to use, is written with the new residential redesign level of services being in existence. So when Pat Lincourt and her team and you know, folks from the field wrote that, it assumes that it's part of our system, and so everything we're trying to do has a connection, and I just wanted people to understand that connection as it relates to that. So you can go to slide 2. I promise to stay on the slides. So as I had indicated, as part of the Medicaid redesign team initiatives, we had to move all of our services into Medicaid managed care. We're bringing all of the adult services, behavioral health services, so OASAS services and OMH services. October 2015 in New York City is the start date, go live date. And then July 2016 for the rest of the state. Children and Children's Services will begin enrollment in January 2017. So as Norvig had indicated, I'd referenced, as part of this move, we started to hear about opportunities that would be available because we were moving our benefits to Medicaid managed care. One of the things at the federal level is when you manage your benefits in the Medicaid system, new opportunities, new flexibilities made available by federal CMS, and they need to approve this because you're asking them to pay for 50% of some cost in your system in the Medicaid world. So, so you can go to the third slide. So we're now going to get sort of Q&A, and it's based on a whole bunch of history now of questions that we've been asked. But so what is OASAS, or what did OASAS ask CMS for permission to do regarding residential services? So we asked, we haven't are asking, we have, and they've pretty much approved. We're in the final details of negotiation on the terms and conditions, but we asked CMS to allow Medicaid managed care plans to purchase otherwise Medicaid reimbursable services for their members in all OASAS. It should say services or settings right now. State plan will be a future piece, but and those will include residential services. So We want them to be able to buy medication administration, counseling, group, individual, in all settings, including residential. You can go to the next slide. Okay, so are we asking CMS to buy the whole cost of residential services? No, we absolutely are not. Again, we asked for permission for the Medicaid managed care plans as they manage the benefits for their members to be able to buy otherwise Medicaid reimbursable services. So services that they pay for in every other setting, they could now pay for someone who's in a residential program within the OASAS system. Next slide. So when New York City and rest of state go live with integrating behavioral health services, how will that impact Part 820 residential programs? So first off, Part 820 is our draft residential regulation for the redesigned model, and we will talk about what that is and where we're at as we move forward. But as the answer points out, those go-live dates matter. So mainstream Medicaid managed care plans and the health and recovery or HARP plans, they will implement Medicaid managed care October 1st in New York City, July 2016 rest of state. At that time, the plans can contract with Part 820 residential programs in the OASAS system, and they would be obligated to pay for the clinical medical services that are part of the new regulatory structure. Next slide. So now we get into a lot. I mean, we clearly understand that this is a new effort and there's plenty of questions, and by the way, there's no bad question. So, you know, so we've had plenty raised and they're good, and it's good that people go through that process to get themselves to a point where they understand it. So does every residential provider need to be converted to Part 820 when those dates that I talked about, October in the city, July the following year in the rest of the state, January 2017 for the kids? Do you have to be an 820 residential provider when it takes effect, or will there be a phase-in period? So clearly, if we had wanted everybody to convert on day one, we would have repealed Part 819 and rewrote it. We've not done that. So we will maintain the current 819 regulation for a transition period. We haven't set a fixed time, but at some point everyone is going to need to convert to Part 820. And we want to work with providers. They're all at various stages of readiness. To be clear, though, if you are not an 820 provider, you aren't able to participate in the Medicaid managed care and be paid the rates that will be paid, which we'll talk about in a few minutes. So, next slide. So what are the services or the three elements of the residential redesign? The first is stabilization. The goal there is that the individual will receive medically directed care to treat acute problems and adjust early to adjust to early recovery. So this phase, just so people understand, and if you've read the reg and the services manual that we've issued, it hopefully gives you a good sense. That is the first two elements. You didn't catch me, Norvik, but the first two elements yesterday was the phases and elements. So you're here too, Henry, so you can correct me. But
I'm ready.
but this element of residential redesign, stabilization, there's going to now be medical direction. There's going to be more nursing coverage, more clinical staff overall. And the goal there, and this is probably one of the primary targets for us in this initiative, you know, we know and we've dealt with the demographics of the people who come to residential treatment programs in the OASAS system. a lot of co-occurring health issues, mental health issues, on multiple medications, not in most instances having the staff that are, best able to manage those situations and to stabilize somebody as they start this path forward. So it's not 24/7 medical coverage, but there is obviously a medical, service component to that phase, that element, I'm still going to do it, of residential redesign. Rehabilitation, there still will be medical, clinical intervention. It's far less. And then the third element is community reintegration. And that really, at least to begin, the transition and implementation of residential redesign, we're really bringing into this arrangement the existing community residential system and supportive living system as they are. Our goal as we move forward and as we figure out the way things, ultimately are implemented, the cost of everything, and whether it, leaves additional funding available. But our goal is to enhance the staffing and most likely introduce Medicaid participation directly into those two settings, but to start, we're not going to do that. And just to be clear as well, in the community reintegration element, we're actually going to we're going to modify the regulation, the Part 820 reg, to have, community reintegration in a congregate setting and community reintegration in a scattered setting to really try to capture. So the new staff, and I know this has been one of the largest concerns that's been raised to OASAS staff, to start, we're not going to change this, but our goal is to change it and to bring it, into a different place. And the one other thing I would say, and it might make a little more sense as we move through the slides, if you're going to provide all three elements, so you're including community reintegration, we probably will look at that and the staffing there in a much different way, because you're providing all three elements, and we think there's much more opportunity to bring additional staff. They're already going to be there. So, and we'll work through with providers, but I don't want anyone to, conclude this with any misunderstanding. So, next slide. Which of the current treatment modalities will be included in residential redesign? So it's intensive residential, community residential, supportive living, and the medically monitored crisis. And actually, what I need to say about medically monitored crisis, which is in Part 816, there will be a transition period for that as well. So we will maintain the existing parts of 816 for the medically monitored, but if you want to participate in Medicaid managed care, you will need to move to that. And actually what I should say is you will have to at some point, because we will move these modalities all in ultimately. Next slide. Will there be any funding available for the programs to hire the new medical clinical staff? So as I had pointed out, clearly in the first and second elements of redesign, there's going to need to be new staff. And what I can say, at least at this point, is we are working on identifying and accessing funding to provide to the providers so they can hire buy the doctor time, buy the nurse time, additional staff, so you can hit the ground running. We're still working through the funding that's available. And so when we have more definitive answers to that, we will put them out there, but we are clearly working. We get it. We want providers to be able to we don't expect that you're going to be able to take the leap with everything else that's going on and hire medical staff and absorb the cost on the front end and be able to hopefully make it up over time. So we are looking for startup funding. We have what we believe will be some pretty good things to announce. They're just not solidified yet. Next slide. Will this residential redesign apply to adolescent and children's services? The answer is yes. It will apply. As I had indicated, children and children's services aren't moving in until January 2017. We are talking, though, about whether we have an opportunity to accelerate the transition for residential redesign for our adolescent system earlier than January 2017. We'll have more conversations with those providers in particular as we move forward. I've had many of them, I think we all have, approach us indicating that they would like to offer that level. And there's always been this issue about, so just to be clear, when we say adults, when we're doing this work, it's 21 and up, it's 21 and over. And we know our system's different in terms of the age mixes and the different programs. And I will say another point, though, is that we're not going to build into regulations, age categories and things like that. The perspective of our commissioner in this agency is if we can't trust our providers to use sound clinical judgment and our other devices to oversee providers and make sure they do things appropriately, and then introduce Medicaid managed care plans to help us also oversee, then we're all in big trouble. So, I want to put that out there. So we are looking at whether it happens sooner, but yes, it will apply to adolescent and children's services. Okay, next slide. Will there be separate licenses for the 3 elements of residential redesign? The answer is no. So you will receive a Part 820 license, and then we will have a separate process to designate the elements of Part 820 that you're going to provide, and they will be noted on your operating certificate. And so let me say a little more about that. So if you're a provider and you have 50 beds, and you decided you want to be designated, and you go through a process of designation, which is not a full-blown application, it's going to be as close to the equivalent of what we do for the ancillary withdrawal. There's going to be protocols and other things submitted to Pat Lincourt and her division, Practice Innovation and Care Management, and to Dr. Morgan, our medical director. And so you've gone through that process. You have 50 beds. You've decided you were approved and designated to provide the stabilization and rehabilitation elements of residential redesign. You have 50 beds. We're not going to go through a 25 this, 25 that, 35 this, 15 that. You have 50 beds. You have staff in the building that accommodate the needs that we want accommodated. You fill your beds based on the people who walk through your front door. And so, that's it. When you read the reg, I hope you see that we've tried to do with this reg what we've done with others and what we'll continue to do, which is regulations are minimum standards, and which, by the way, most providers far exceed. So that's what we're trying to do, and we're trying to create ultimate flexibility here. As I said, your marketplace is going to be Medicaid managed care plans, but also private and commercial insurance plans. So we're trying to give you the ability, and Locator appropriately drives individuals to this level of care. We think it creates great opportunity. We want to give you the most flexibility possible to do that. Next slide. As a residential provider, a Part 820 provider, do I have to offer all 3 elements of recovery? And the answer is no. You can offer all 3, but you'll not be required. again, our goal is to not only preserve existing treatment programs and locations, but to give you the ability to figure out what you believe is the best levels of and best elements of services for you to provide. Next slide. I sort of hit this, but yeah, I mean, I answered this one, but yeah, we're giving you ultimate flexibility. Your certified capacities and overall capacity, you will have flexibility. I mean, I do have to say, you know, the designation process won't be, I want to do this. Thank you. You're going to have to show us the kind of staff you're going to use. You know, it's so, you know, protocols that you would use, because you could potentially do detox within the setting. So it's up to you what you want to do, and we need to make sure that you're going to, that you've created policies and protocols that tell us that you're going to protect the people that are in your care. And if we are satisfied that that indeed is the fact, you know, the case, you will be able to do what you've requested to do. Okay, next slide. Do I have to become a Medicaid provider? So the answer is yes, but it should be yes, right. If you are providing stabilization and or rehabilitation elements, you must be enrolled with DOH as a Medicaid provider. And that's at the beginning. As I said, there's work we will do as we move forward on the reintegration elements, but clearly the first two you will need to be in Medicaid managed care. Okay, next slide. This is an old slide. I had heard this at one point, so I put it in. I don't know, to humor myself or. You want to do this one, Norvin?
Well, they initially when this project started, partly because of some of the movers were TCA members, there was this feeling about that by some people that this was a therapeutic community project and how to bring therapeutic communities into this, and it would be that type of service that was driving this, and that wasn't the case even at the very beginning. It just happened to be that, you know, the TCA group, which includes a lot of providers, a lot of services, got interested in this very early on, and it's not driven by therapeutic community interests. It's not for therapeutic communities. It's simply how do you bring Medicaid into the residential treatment venue, regardless of what your particular treatment philosophy is.
And yeah, just to expand a little, you know, the medically monitored crisis services, I mean, you can see in the reg, it fits in. And I'll tell you, I mean, another thing that sort of overwhelmed all of us, or at least overwhelmed our thought process and conversation, is the epidemic of heroin and opioid abuse and misuse. And you know, for us, it's become even more critical that, you know, because medically monitored is really a short-term residential stay where you're trying to stabilize somebody. So we think it fits into stabilization. Another thing that you know, we think is critically important, that we want to answer a question that all of us have been asked far too often, that usually hasn't been answered well and has led to some pretty tragic circumstances. So it's my son, daughter, niece, nephew, addicted to heroin, prescription opioids, ready to get help. I took him to the hospital to get detox. The hospital said they don't need that level of detox, and on a clinical review perspective, they are correct. But the answer they received, take them home and let them withdraw in their bedroom, and it don't work. So, but what we haven't had, and which we're trying to create, and we hope providers, you know, take this opportunity, the stabilization element offers you the opportunity to treat those kids and the person who needs a longer length of stay and to go through multiple. So you can do short-term detox, withdrawal, stabilization, and longer-term treatment, so that then we'd be able to tell these family members, they don't belong in a hospital program, but they could go to this program, Stabilization, they could go there. Because they do need, quite honestly, to be someplace other than their house and their bedroom. So we thought this made sense prior to what we've been dealing with over the last couple of years. It's become even more crystal clear for us and quite honestly, even beyond heroin and opioids, because unfortunately something else will come at some point that's the new crisis. And it's unfortunate, but it's our system. It's what we all deal with. It's what we all get involved to try to do something about. So these short-term beds are always going to be needed. But the thing is, the medically monitored as currently exists needs the enhanced staffing just like the long-term residentials do. So, so that's the answer to that slide. We've not turned it over to TCA. Next slide. I think we somewhat answered this, but so will we mandate staffing levels and regulation? Absolutely not. You saw in the draft 822 regulation, we are not going to do this any longer. You can determine what's adequate and appropriate staffing by means other than some non-peer-based, non-evidence-based ratio that's been developed and put into a regulation. So we will have plenty of guidance out there about what's appropriate, but we're not going to put that in regulation. We'll look at it. Clearly, there has to be some indication of it in your application for designation for the various approval to do the various elements, and there will be guidance out about what the right clinical standards are at the time, but not in regulation. Next slide. Can I share staff from other treatment programs within my agency? And the answer is yes. You'd have to indicate that in your designation applications, but clearly you need the appropriate amount of time because you are being reimbursed for that. So within reason, yes, you can share staff between programs, which you can do in other settings now. So, next slide. Are you taking away the state aid from OASAS and replacing it with Medicaid funding? My computer keyboard just kept typing no. No, it's for emphasis. I've heard this in I don't know how many different forums all around the state. This OASAS is taking state aid out of its system. It's not true. It's absolutely not true. I've said it, the commissioner said it, Pat said it, Henry, Ileana, Norbert. We are, this opportunity, what it created for us is the following. We needed enhanced staffing in residential. We've known that. We can get federal and state Medicaid to pay for that now. So it's new money in on top of the funding that you already received, be it state aid, block grant, congregate care level 2, food stamps, personal needs allowance. We also hope, by the way, more private insurance revenue. But we are not taking our funding away because we're replacing it with Medicaid funding. We're asking you to bring new staff in. So we've created new cost. The new cost, we finally found a way to pay for it that makes absolute sense in the way you do business. So we're not taking OASAS state aid out of our system. And because the question really, the next slide, you can see the question sort of irritated me, so I just sort of restate what I just stated. You will get paid, but to be clear, I want to say one thing though. You will be paid for the medical clinical services that you will now offer. You'll get, from the managed care plans, you will be paid a Medicaid per diem rate for those services. And those rates, by the way, are in the services manual that we sent out and we think actually, and kudos to Pat Lincourt and Sarita Wells and others in their work with DOH, but I think we're in a very good place with that. But so that's new money in, but it's in to pay for those new staff. The other forms of payment, which I had already identified, are out there. They will continue. Next slide. Wow, I really beat this one up. I don't need to say anything.
It's getting repetitive.
Yeah, I think I'm putting an X on this slide for the next presentation. I will tell you, though, it has come up in every place we've gone in the last year. So next slide. How will my program access the residential per diem? So stabilization and rehabilitation programs, obviously, which we said will be in, will access the appropriate per diem via a contractual arrangement with the with your patient's Medicaid managed care plan. Medicaid fee-for-service will, as we move forward, only be available in the following limited circumstances. If the program is a Medicaid provider less than 16 beds and serving Medicaid recipients not enrolled in Medicaid managed care, I can tell you, and I'm looking at Ileana, I think that's going to be a very small universe. So it is possible, I guess, if you're under 16 beds to get the rates, but most people already are, and we believe will be, in Medicaid managed care who access our services. So next slide. This is a slide, Ileana would beat me up if this wasn't in here, but in terms of provider support, we have worked extensively with Casa Columbia, which is our partner in the relationship with that's part of the Managed Care Technical Assistance Center. And we're working with them specifically on residential redesign. There's going to be, they're scheduling a series of regional forums starting later in the summer to go around and try to assist programs as they think about how they would implement a redesign model in their system, in their programs. And then in addition to that, there will be ongoing learning collaborative, and there will be forums for that, trying to continue the conversation. So there will be more on this. And so I think with that, we are finished with the slides, and I know there are no questions because everyone understands it completely. What's that? Huh? Yeah.
The first question has to do with, is there a difference between 21-day inpatient treatment and congregate care in a halfway house or a long-term setting?
So 21-day inpatient treatment, I think you're talking about inpatient rehab. That's still separate and apart from this. Congregate care in a halfway house, so that for us is community residential, that's going to be part of the reintegration phase. It will exist, as I said, as it does now. It will as we move everything to 820. So there is a difference. I mean, the inpatient rehab is a short-term, 24/7 medically staffed level of care, and that's the most important distinction. It is not what we're talking about, especially with the first element of residential redesign, is not a 24/7 on-site doctor, nurse staff. It's on-site for at least a shift, Pat, probably?
There's nursing on every day.
Nursing every day, every shift?
Not every shift.
So nursing on-site for at least a shift, right? And then doctors on call?
A doctor on call, and then we're looking at about 9 hours in a stabilization phase on-site.
Yeah, so you can hear that it's far different than inpatient rehab. And I know there's been some concern that you know, compromising inpatient rehab. No, in fact, I think we're highlighting, you know, it should be easier, especially when you use locator, for people to identify those who need that type of care and those who could function and be safe in this lower level. So you can hear they are not in any way close to each other.
The next question was whether or not Westchester County programs are included in the New York City region or the rest of the state.
What?
Westchester County is rest of state for, in terms of carving in for the members, where there is a little bit of distinction would be that if you're serving New York City members of Medicaid managed care plans, you could seek to be in the network and make the transition if you felt like the volume of that population was higher.
Yeah, what I would say to Westchester providers is contact us on that. We are concerned, and we've explained this to DOH and OMH, that a lot of our residential services are provided to New York City residents outside the city of New York, and it's our expectation that they are part of the networks in the New York City Medicaid managed care plans, or else this exercise doesn't work. So, so I think they understand there's a uniqueness in our system about the places that their members will receive treatment. So I think this on some level fills into it, but yeah. When will the proposed Part 820 regulation likely be published? Well, it's in draft form on our webpage, right? If you go to our laws and regulation page, we posted it there in draft form a month ago. And I sent out an email. I send emails to like 1,000 people now is on that list, so we sent it out when we published it. So, okay.
The next question is talking about clarification for programs that are going to operate or be designated to operate the stabilization element, and if they also operate Part 822 programs, either clinics or rehabs.
Well, you know, we're expecting the services that we're talking about to be provided in the 820 setting. So, you know, you can operate at 822 for other patients in your system, but not for those who would be in the residential redesign. And in fact, I would question if you're sending them there now, whether there's some concern about doing that. They shouldn't be receiving services in an 822 if they're living in a residential program.
Well, the 822 services have been provided to people who are in the reintegration phase.
And that was,
well, but that's different, right?
Yeah,
well, they mentioned stabilization. Yeah, reintegration, to be clear, right? Reintegration is community residential. So reintegration in a congregate setting, right? Our reg says now in 819, community residential, you receive your services, your clinical services in an outpatient program. That will continue. But the services we're talking about for the stabilization and rehabilitation are provided by those programs within those facilities. Like we said, you can share staff between programs, but you can't take them to the 822 to receive those services.
Then there was a question about medically supervised withdrawal.
Still will continue as it is in Part 816. In fact, quite honestly, we hope that there's an increase in the number of medically supervised detox programs. We think managed care will help create an environment for that to occur. You know, I'll step back for a minute. You know, residential redesign is one piece of what we're doing. We're going to also get the ability to have our clinic programs go off-site to provide Medicaid reimbursable services. All of that, from our perspective, is paid for by funds that are now used, quite honestly, for overusing the hospital-based detox system, the medically managed system. And that's the money we're counting on, and Medicaid managed care is working with us to move the funding to where the services ought to be provided. And so Medically supervised, absolutely, is an essential part of what we're talking about.
We received a question about how does residential redesign interface with PARP designation and HCBS services?
Well, those speak to what you're eligible for in terms of additional services. If you're HARP eligible, it's higher use, higher pattern of utilization, you need additional home and community-based services. It's unlikely that you're getting those services in a residential program, because remember what I just said, HCBS, home and community-based services. So CMS is really particular about those being provided to people who are in their homes and in their communities, so they don't. What we do hope is that residential redesign leads to more people more quickly being able to succeed in their homes and communities, and if they have high past patterns of utilization, accessing the additional services.
There's a question about if you can speak to length of stays within the different elements and working with Medicaid managed care.
So I talked about dates and times and numbers not being in the regs a lot, and those aren't in there either. What I would say to you is the Medicaid managed care plan is responsible for the cost of those medical clinical services, and they will ask you occasionally, you know, whether how the person's doing and whether they still need to be at that, you know, that level of care. That will go on, but we're not giving them nor you some magic number of days that the person needs to be in any setting. But what I'll say to you is that not doing that comes with this ultimate responsibility. You know, what we expect to be said to people when they come into your programs is not that you need to be here for X number of days, weeks, or months. What we expect to be said is you need to be in this program for as long as you need to be in this program, and we will work to move you through the program as quickly as clinically appropriate, right? And people will move through the phases as quickly as they progress in their treatment. So, yeah. No, I can. You want me to?
Yes.
So we're getting questions about the new CMS rule limiting IMD stays. And do you want to? Oh, yeah. So we're aware of the rules. We are in conversations with CMS seeking clarification. So I can't say any more than that. We believe that the rules, in particular certain aspects of them, this 15-day piece, is written more from an MH or mental health psychiatric perspective, but we're seeking clarification on that. And when we know more, we'll let the field know more.
For the rest of state providers and the behavioral health services being integrated, you know, not until the following year, how should programs that are interested in converting to 820 status, how should they be getting ready for that type of move, and can they move before that happens?
Well, they can move with the understanding that, you know, they're not in Medicaid managed care at that point, but they should consider moving for a different reason, right? A, we will, like I said, be looking for startup funding to hire the staff. B, you know, this opportunity to become part of the private commercial insurance world, we think it's an immense opportunity. We're doing, and actually Locator, and Pat's been great about it, Pat Lincourt, when we talk to plans, not just about how to work through the tool, but about the different levels of care. And as they learn more and more about particularly the stabilization phase of residential redesign, you know, we have been starting to hear from them, when can I buy that level of care? Because they see the need for it. So I guess what I would say is we will work with providers to try to front load the funding as quickly as we can everywhere in the state, understanding that hitting the ground running when you go into a fully managed Medicaid system might be preceded by already having hit the ground with private commercial insurers. So we will work with anybody. Again, we're leaving this phase in, and that's a statewide thing. If you're outside of the city and you think you're ready, willing, and able to do this, reach out to Pat and start talking to us, and we can start to look at how we can help you move through and get to a point where maybe you do it far sooner than July of 2016.
Could you restate the distinction between community residential and supportive living and their connection to the reintegration element?
They are the reintegration element. Simple. We're bringing them forward as they are. We're not changing your staffing, so the reg's being modified to basically transition what exists now into what is in 820. But I need to be clear, two things. One, our goal as we move forward is to enhance the staffing and potentially bring Medicaid participation like we are in the first two elements into that element. That's one that needs a little more work, but we will be working on it. And then again, if you are a program that's going to offer all three elements, we're going to look at your staffing on that last element differently than we would if you're a standalone community reintegration in a congregate or scattered setting. So with those understandings, we're carrying forward what is now into at least the beginning of residential redesign.
Could you speak to the role of KSACs within the last element, so the reintegration element?
It seemed like the question there was about care coordination and KSACs, that each person needs a care coordinator, and then KSACs are referred to as care coordinators. It does not mean that every person who's providing care in a reintegration has to be a KSAC, but there should be a KSAC to provide care coordination.
Require that now. Yeah. I guess I want to say one other thing as Ileana's reading through the questions. You know, we're setting the minimum standards. You are, you know, we will work with anybody who wants to accelerate the process, and we will always welcome providers exceeding the minimum standard. So, you know, we really, you know, we understand the anxiety of making this move to Medicaid managed care. I think we've spent and will continue to spend an extraordinary amount of time working through the issues, trying to create other protections, which we're not talking about here, but we've talked about elsewhere. But we think there's huge opportunity here for you to, you know, to offer the services the way you want to and in a way that we think insurance will want to purchase. So methadone residential program, is there a plan? For the 5 that are out there, we will talk. There is a plan. They are part of this, and we'll talk about that separately. They've been one of those special things for me as we've worked through these issues. I get everything about it. You are protected. We will work with you. We will work through that issue. And for the 5, we will meet with you separately. How will IPMIS change? Where's Gary? It will. But, and we've met with our, you know, our OMSI folks. They know what we're doing. So they're in the midst of making adjustments as well. So, you know, I want to say, as we make this transition, so between regs, between different ways of doing business, between what IPMIS is now and what it will be, we understand the period of, or the concept of grace periods, and so we understand with all that's going on, we would probably focus more on you being able to do the fundamental pieces of what we're talking about, and the challenges that are going to come with you trying to compete in a Medicaid managed environment. So we understand, and I hope that you feel as we move forward that we're focused on the fundamental elements of implementing properly and protecting health and safety, and maybe less focused on all the nitty-gritty details of how we judge performance. The plans are going to be judging you in this first 2-year period. So we appreciate the question. It will change, but let's not focus on that piece right now. We will, as we move forward, focus more on being able to get yourself prepared to compete in a Medicaid managed care environment.
We have more questions coming in.
Yeah.
So we're coming up against the 4:30 time. So we can catalog questions and put together an FAQ follow-up document. Is that?
However, what's the timing? We're off at 4:30?
Mm-hmm.
Yeah. Do we have any, like one more?
Maybe that one.
What's this?
820 programs requiring a medical director?
Yes.
Or if they provide
for the stabilization
and rehab. Yeah.
But it's not a full, it's not.
That wouldn't be required for the reintegration.
Right.
Yeah. No, it's not a full-time medical.
Yeah, it's like, yeah, but there will be medical direction.
And finally, there was a question about the services manual and how people could get a hold of that. So.
I don't believe it's on the website.
So we did send it to that email list. Sarah Osborne's here too. Can we work on getting it posted with the 820 reg?
Yeah, I don't see why not.
Yeah, so we'll get it posted as soon as possible on our webpage. It will be right next to the 820 regulation.
Great.
Okay.
And then we've got a list of all the other questions that have been asked if we can't get to them.
Okay. Is there a proposal out there regarding the easing of Suboxone prescribing regulations? The question came up. Well, I will say quickly then, as part of the move to Medicaid managed care, we've also been working with Department of Health pharmacy staff, and we are making changes to the way medication-assisted treatment is handled in Medicaid managed care. First and foremost, Vivitrol, which is right now in the medical benefit, which then means it's very difficult to access, and I think people have to buy it first and then bill for it after. It will become part of the pharmacy benefit. And another key piece, I think probably more connected to Suboxone, there are provisions in the Medicaid managed care contract that speak to emergency circumstances, and obviously without our services being in Medicaid managed care, they didn't include us, they will now, so we have, we're adding provisions that speak about emergency access to addiction medications, and that needs to be allowed under the contract that the managed care plan signed with the state of New York. So appreciate everybody joining. We will take all the questions, we will answer them, we can post them on Pat's page, as I called it yesterday. On the managed care, I'm sorry, the Medicaid managed care page.
Put the
otherwise known as.
And the answers on another.
So thank you all for participating. We'll answer all the questions, as we always do. And, you know, stay tuned for the other forums. You can look on the managed care page as well for that, and we send the emails out. So stay tuned. We will continue this effort to try to, I think it's more answer questions and clear up what we're trying to do and what we're not doing. So So thank you all.
Thank you.